So, thanks for coming. Appreciate it.
Let's see here. I've been out for many years, so.
Out like out of jail, like.
As in out of school. I graduated from OEPA program in '06. I remember, I was yesterday in your spot. They punish you with a Friday afternoon, 1 o'clock.
I know, that was me.
So, I was going to try to make this quick and painless. How much have you received on lung diseases so far? What's a little?
A week and a half. We talked about COPD, emphysema, chronic bronchitis, a little bit about asthma, a little bit about
a whole bunch of cystic fibrosis.
A little bit of lemon.
Yeah. Through, you talk about medicines or just individual? Okay, kind of like cannabis. Then this will be very, very easy. I'll go through asthma first. I've got a few inhalers. I've got a handout for you guys. With asthma and COPD, there have probably been more medicines that have come out in the last probably 4 or 5 years, the last 10 years combined. So it's a lot. So when I get students in my office, that's the one thing that's kind of troublesome for them as far as knowing the medicine, knowing the categories. Because I know everybody's worried about tests and what should I know. That's always the main thing I always worry about is just getting through, right? So I'll kind of highlight what you need to know as far as kind of boards. Testing wise, it will be really the same stuff. So when I say this is important, this is important, okay? Asthma, chronic inflammatory disorder of airways, episodes of reversible inflammation causing airflow obstruction. Main word,
Obstruction.
reversible, okay? Increased responsiveness to a variety of triggers. That's one of the, and we'll get to it later on in the lecture. Triggers is the main thing. When you start talking to a patient about their breathing, that's the number one question, I shouldn't say number one, but one of the main questions you ask. Are there certain times or certain things you get around that trigger these events of cough, wheeze, shortness of breath, combination of all three, right? So pathology, you guys have kind of covered. Airway inflammation, mast cell activation, inflammatory cell infiltration, neutrophils, eosinophils, T lymphocytes, that whole business. Please don't let that be on your test. Just don't do that to them. Alright? A lot of it is details, broad stuff, guys. Alright? Hypertrophy of the bronchial smooth muscles, mucosal edema, mucus production, airway, muscle tightening. When we go through here, I'm a big picture fan, so if I can't see it, it's hard for me to understand it. So there'll be pictures throughout here. I mean, if asthma came with a pop-up book, I would have done much better. So, in this picture, you can see normal airway compared to when you have asthma symptoms. This is a very good, the reason why I say pictures, it is very difficult to understand, oh, it's smooth muscle tightening. Oh, you know, restriction. Look at the picture. You have these areas of bands, right? Smooth muscle bands, smooth muscle airway along that airway. When that gets inflamed, that's going to get tight. It's going to be very hard to breathe, right? As you can see in the asthma symptom airway, you have a lot of swelling, the airway wall, a lot of inflammation, a lot of swelling, a lot of excess inflammatory junk that kind of lines that airway, making it very difficult to breathe. Oh, let me back up. I do adults. Kids freak me out. Okay? Because asthma in kids, and we'll kind of go through this in a little bit, is very, very scary. A lot of you that will go into primary care, I shouldn't say primary care, urgent care, ER, kids can go south really, really quick. Always be cautious of a kid with asthma problems. You'll run into parents who kind of blow it off like, hey, it's their usual. Don't do that. Be very cautious with kids. I've seen it go bad real quick. Bad story. little girl, 7-year-old. Her mom was a nurse, a very, very good hospital nurse. Her husband was a football coach at a local university. Her only daughter, they had 4 boys and that girl, only daughter had bad asthma. Started having some trouble breathing, gave her breathing tube. Nothing worked. Called the wife. Oh, she's fine, give her another breathing tube. Nothing worked. Hour later, hey, she is not doing too well. Give her another breathing tube and get her up here to the hospital. By the time he got that girl into the car and forgot whatever he forgot in the house, went in the house, by the time he got back, she was blue. Okay? The kids freak me out. Okay? Why do that? Girls and grumpy. I like them. Alright? They have to deal with parents. Anyway. Factors for developing asthma. It goes back to when you have a patient come in being worked up for, shortness of breath, and you think they have asthma. A lot of these things you need to ask about. Family history. 40 times more likely a parent has asthma. You will also get the adopted child who has no clue. Okay. Socioeconomic factors, race, ethnicity, gender. Boys are greater than girls. Prematurity, you will always have that prematurity birth weight. You will always have the story of, I was born 4 pounds, but I survived. Yeah, you'll get that a lot, trust me. Atopic, again, ask them about allergies. Eczema, obesity. Trust me, they're obese, they're sort of bred low respiratory infection. RSV, PIV, that's parainfluenza, if you guys thought anything different there. It's not PID, it's PIV. Alright? Adenovirus, chlamydia, mycoplasma, diet, and mother smoking. Risk factors. So we'll talk about this a little bit later. When you're doing the workup. Environmental risk factors, allergens, dust mite, animal dander. Always ask, even the parent or the patient themselves, do you have a dog in the house? Do you have a cat in the house? And I'll give you this for lung disease. Do you have birds in the house? Okay? Cockroach, indoor mold, outdoor mold, pollen, irritants. And so, and you can see them there. On the allergen, when we're doing a workup of an asthmatic patient, you can start to tell the difference between extrinsic and intrinsic asthmatics. Those extrinsic people are the ones that they know their triggers. They know it. They get around, I get around smoke and I lock up. Those are the people. Lately it's been the red cedar's out, I'm doing bad, all the time, right? They know it. You can get to a certain point where you've maxed them out on therapy, but nothing is working. Start thinking about doing a true allergen workup on it, okay? The panels that we run are, one is a Midwest panel, allergen panel, that covers, there's probably about 6 different types of trees, grass, all in this kind of Midwestern area. I think there's 4 or 5 different types of mold, grass, trees. Then there's another one called a perennial panel that does for the dust mites, cockroaches, cat dander, dog dander.
And you're talking serum blood
Yes,
draw
yes.
versus
Yes,
the
besides the skin prick. Skin prick is very objective, and we'll get to that. Because from an asthma standpoint, there's been several drugs that have come out, biologics, injectables, right? Some of those, you get to a point where you get that bad allergic asthmatic, that those drugs don't count, right? If your IgE is too high, if your eosinophil count is way too high, none of my drugs work. That's when you go to immunotherapy. Even sometimes with immunotherapy, if your allergen panels, if your skin prick test, and you have whelps that are this big, even your allergist is going to say, buy a bubble, don't go outside. I mean, it gets to that point. Some of our guys, not a whole lot. There's other panels that are food allergies, nut allergies. I don't do those a whole lot unless patients request it. I talk to them about it, but I don't order unless they really need to. Other triggers, viral illnesses, cold air, weather changes. And when I say weather changes, it's Oklahoma. this week, it's supposed to be like winter tonight, then like golf on Sunday, like it's ridiculous, right? When we talk about weather changes in cold air, it's not just outside. It can be simple as they walk from a cold air outside to a heated office room inside. It has happened in my office. Just the quick change like that sucks it right out of it, okay? A lot of times that's not interesting to me. Emphysematous patients, but they have asthmatics as well. Emotions, foods, medications, exercise. Another one, going back on the irritants, fumes, paint chemicals and sprays. It can be, you know, chemical or cleaning supplies. Bleach is awful, okay? They really have to spray the room and get out, okay? We had our cleaning crew in our office had waxed our floors and shampooed the carpets. A asthmatic shows up the next day. She was about, I don't know, a couple of breaths shy of me intubating there in the office. So, make for a fun little morning. My student was excited. So, asthma signs and symptoms, it can be anything and everything, okay? Mild to severe, episodic wheezing, chest tightness, shortness of breath, cough. Severe attacks, when you see an asthma attack, you'll never forget it, because it is bad. Patients look at you for help, and they cannot breathe, okay? They are gasping for air, and it can not be a pretty sight, all right? Use of accessory muscles, nasal flaring, unable to talk in sentences, diminished breath sounds, audible wheezing, respiratory distress, anxiety, panic. Big time. James why I know the kids. Okay? If you notice what's in red, very important. Okay? Amount of wheezing is not a reliable indicator for severity of episode. Okay? I have plenty of asthmatics that are completely stable and I can hear them from the doorway. Okay? But that's just them. No matter what you give them, you give them steroids on a daily basis, it doesn't matter. They always sound awful and that's just them. Okay? That's my pulmonary office. So, when you see someone like that in primary care, urgent care, they know what their normal is. Be sure to ask that. Okay? I find that a problem a lot when I get patients back from urgent care or ER. They'll say, well, I had my usual short. I went in for this, but they heard me wheezing. They gave me a bunch of steroids. That was their normal. Okay? So again, we go back to this picture of a constricted airway. Symptoms, physical exam, physical findings, I should say. Kind of same thing, tachypnea, tachycardia, hypoxic. Sometimes, just make sure to check it. Always have a pulse oximeter nearby. Percussion off the normal, hyperresonant, low diaphragm. Palpation. You guys do primitives? Hey, they learned it, I learned it, you did, I learned it. Don't tell my bosses that.
I have a question.
Yeah.
What do you mean by low diaphragm in the
Hyperresonant, so it's gonna be a lot louder.
Like
So-
diaphragm is low?
It can be, yeah, but,
Okay.
yeah, that's it.
Okay. Thanks.
Yeah, that's pretty, yeah. On initial assessment, again, it goes back to take a good history. That is the most important thing. You can really pinpoint stuff, just ask the right questions, okay? Going back to family history, environmental risk factors, exposures, symptoms, what they tried in the past, what has worked for them in the past, how often, and this is, the next few slides are some of the best questions you can ask, okay? Past 12 months, severe episodes or recurrent episodes of coughing, wheezing, and shortness of breath. This one is a very common complaint. When you ask them about colds that go to their chest or take more than 10 days to get over, what they'll usually present to you with is I've had this cough for 3 to 4 weeks and just won't go away, right? What did it start with? It's usually, I had bronchitis, I had viral illness. They feel fine, but they have this lingering cough. And sometimes this post-viral cough can last 6 to 8 weeks. Underlying lung disease, that can last even longer. A wheeze can last a lot longer, even though you feel fine, they just still don't feel very well, okay? Your lungs are very finicky creatures, okay? They will hold a grudge against you if you make them mad. You have to play nice, okay? Because they will definitely hold a grudge for a while, okay? Coughing, wheezing, shortness of breath during a particular season, time of the year, they know bad, extrinsic asthmatics. You know what? January through February, my allergies are awful, my asthma is even worse. I start using my rescue inhaler 4 or 5 times a day, beginning in February. You'll hear that quite a bit. Okay, coughing, wheezing, shortness of breath in certain places when we're exposed to certain things. Again, animals, tobacco smoke, perfumes. We can't test for that stuff if you have an allergic response to that. A lot of times it is patients telling you, say a mom goes and visits her daughter who has 2 dogs. I do fine until I go visit my daughter. It's the dogs, okay? Did you have symptoms of heartburn or awakening with its acid taste in the back of your throat? Did you have symptoms of post-nasal drip or sinus congestion? These questions help you with the differential and kind of figure out what may be other triggers or other reasons why they're coughing or they're wheezing, okay? I'm sure you guys go on with chronic cough. Wow, blank. No. Anybody differential with chronic cough? Anybody? I'll just give you 4 things.
COPD.
COPD is like in one.
Lisinopril.
All right, so we'll do this. Chronic cough, very easy, right? 4 main things. I should say easy, right? But, yeah. Number 4. What'd you say? Lisinopril, somebody?
Lisinopril.
Drug side effect, okay? I'm not a smart man at all, right? You come to me with chronic cough, I immediately look at your medications for that one thing, ACE inhibitor, okay? Trust me, people think I'm an amazing provider. I have one little thing. I don't do anything. I tell them to stop, right? Number 3, upper airway cough syndrome. Very polite way of saying you got too much snot. Get it under control. That's all it is. Upper airway cough syndrome. Okay? It's I cough more when I lay down at night. I have constant drainage. And you can look by exam. A lot of fluid in their ears, postnasal drainage. The sinus pressures, a whole bit. Okay? Number 2, reflux. Very important. Okay? You can get silent aspiration with reflux. Make sure you ask the right questions. Don't just say, hey, do you have reflux and do you take the medicine for it? That's one thing. Because trust me, the response of, here you go, how often do you have reflux? Not that often. Trust me. That right there is a very variable answer. Because to them, they've been so used to it that they're not very often is, I throw up my mouth 3 times a week. Yeah, that's not very well controlled. Okay, and they don't understand that because that has become their norm. Hey, how often do you, get that acidic, bitter taste in your mouth? Oh, after every meal. Like it's a normal thing for everybody to do that. Okay? Make sure that is well controlled. That is a common issue. Then obviously number 1, lung disease. Okay? So again, that heartburn, awakening, acid taste in the back of your throat. Okay? Because again, they'll have a complaint. Make sure to ask, hey, when do you cough more? Morning, noon, night, laying down. With laying down, think 2 things: reflux or drip. Okay? It's pretty broad, but right? Wheezing, cough, chest tightness, shortness of breath, is awakened to at night, in the early morning, after running, moderate exercise, or other physical activity. Some people will have this exercise-induced asthma. Okay? Make sure to ask these questions. Has any medicine that has helped you breathe better? How often? Are your symptoms relieved when these medicines are used? Because, again, if you're working pulmonary, urgent care, primary care has tossed everything out there. Okay? Usually first, short-acting beta agonist like ProAir, albuterol. Okay? You take them every day, you use a chamber or a spacer. With the chambers, I didn't bring one, I may have a picture of one.
Our next gal might,
Yeah, you guys got 2 hours of spirometry.
actually, you.
I'm about to cover 3 lectures in an hour and a half. You got 2 hours of spirometry.
Bobby. Bobby.
10 minutes. Alright. So with the chambers, some of my docs use them, some don't. They can help with the inspiration of inhalers. Also can help decrease building up the risk of thrush. Okay. Does your child wear a mask with nebulizer treatments? There's slides about kids later down. Yeah.
So do you guys prescribe chambers for your adult patients as well? Because I always thought that it was a child couldn't inhale the inhaler correctly type of thing.
We do both. I mean, how old are you talking about? Like kid-wise?
I mean, well, I worked in the pharmacy and we saw like 13-year-olds coming through with chamber prescriptions.
Yeah. Yeah, absolutely.
Okay.
Yeah, adults too. Yeah.
I guess we were, or I was always thought that it was more like a kid can't do their inhaler correctly type of thing.
Hang out with me for a day. You're gonna see a lot of 70-year-olds that do not do that correctly. Yeah. So, I don't use it too often, but sometimes if they don't get that big inhale enough, sometimes it allows them to take that second inhalation and get the full dose. Diagnosis of asthma, again, it's all about asking the right question, okay? Exposure to triggers, allergen, exercise, infections. If you stay away from that trigger, your symptoms improve, okay? Wheeze, you know, cough, you know, shortness of breath, you know. Again, this episodic symptoms of airflow obstruction, at least partially reversible, and we'll talk about that with spirometry briefly. All right, briefly, you really love it. All right. Airflow limitation on initial spirometry. We do in-office spirometry. A lot of primary care offices do in-office spirometry as well. It is a very rough guesstimate on their lung function. One, you have to have a good MA that's been trained on how to coach your patients and do it properly, because there'll be pictures here in a little bit, but she'll go over that later. You are really having to stick a toilet paper roll in your mouth and try to blow. So it's very hard to get a proper seal, blow correctly, okay? And you know, someone should really yell at you to blow, 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 blow. I think it's constant, okay? Hopefully she'll make something to do that. Okay? Increase in FEV1 of at least 15 or 20% following bronchodilation. Again, you get a baseline FEC, FEV1 and ratio. You give them a bronchodilator, then you retest. How much did it improve? Okay? Again, I think there's the next slide or two we'll cover. So, FEV1, like this says, may be normal at the first office visit. You can have a lot of patients with normal lung function, period. Okay? If you think that they are more of an allergic component, order what's called a methacholine challenge test. And then methacholine challenge test, okay? It is what I refer to as the poke the bear test, right? So I know you have normal lung function. What happens when you get around something that your lungs don't like, right? So what I'm going to look for is that FEV1. FEV1 is the forced expiratory volume in the first second. So when you take that big a breath as you can, when you start forcing air out, how much you blow out of that first second, okay? I look for more than a 20% change in that FEV1, okay? So I give you an inhaled irritant, poke the bear. See what happens. Recheck your lung function. Recheck FEC and FEV1. Oh, nothing happened? Bigger sick. Give you a bigger inhaled irritant. Recheck it. Nothing happened? So I go through 5 levels. Somebody does. Look for a change greater than 20% in the FEV1. Okay? That shows the hyper-responsiveness, hyperreactivity, i.e. reactive airway disease, okay? Some are much worse than others. Some that you would bet your paycheck that, oh, you're gonna be positive level 3, you're gonna have tons of allergies. Those are the ones that will fool you, okay? And you'll be scratching your head trying to figure out what to do next, okay? That's when you obtain blood work about their allergens, all right? Spirometry, again, this is basic canopy spirometry. They actually have a good flow. You can see that. Nope. All right.
If you move the mouse over on
Hey,
the
let's do that.
screen. Here.
So this is actually a really good effort because when they're blowing out, I mean, that is really good. You get a better idea of the pre and post. They did post. Oh, they actually did. Good. Again, FVC, 89%, FEV1 of 61. So you can call it moderate obstruction, right? Ratio less than 70, FEV1 less than 80. Okay? Okay? But again, look how much that improves after the bronchodilator. That's incredible. You're improving 53%. Your lungs have a lot of reversibility. On board exams, you will probably get a spirometry. Something like that. Okay? Again, spirometry, we'll go over that later. Again, look, FVC, FEV1, right? So, wow. So, FVC is 73%, FEV1 of 39%. Again, I'm looking for FEV1 of less than 80, with a ratio less than 70, and that is 43. And that's kind of COPD. Total lung capacity, 123%. That's more like, but, that's bad. Anyway, we'll get more spirometry later, I don't know.
What was the name of the test where you had him repeat the levels?
Oh, methacholine challenge.
Methacholine?
I have my husband's.
Hey, that's awful,
test
yeah, level 3. I can see it from here.
Here. Want to look at it, or if you want to take him, do you want
No, no. He's got poor reactive airway disease.
to?
He's got bad reactive airway disease. Yeah, so, and he has the pretty typical what you see, all right? So, this is all HIPAA, right? You're okay with it?
I don't care.
Okay. I have to ask. Okay? So, when you look at this, and this is what we're talking about, the methacholine challenge test. So, level 1, I give you an inhaled irritant, you only change 7%. Level 2, a little bit more irritant, you change 12%. Level 3, you turn positive with a 30% change in FEV1. So, think about it like this. It's not to the extreme, but if you're blowing through a toilet paper roll, also you go from that to blowing through a straw. Makes a huge difference, okay? This is typical of what you'll see, kind of this gradual, I didn't change any of the first one, second level I changed 5, then 8, then 10, then kind of late stage positive. I've had some with a 45% change in the first one. Yeah, so you can get all varieties, but be more conscious, I guess you'd say, about the ones that change quick. That is very gradual, and that's okay, but it's the ones that jump off the cliff, that no change, no change, no change, 40. Those are the ones you have to worry about, because if they get around whatever tree that may be, they can go down quick, okay? It's just going quick, it's just, their symptoms can be pretty bad. Quick, I should say. Flow volume. Peak flow. Again, she'll probably go over this when she does spirometry. We have a lot of our asthmatics on peak flow. A lot of pediatric offices will do this, pediatric pulmonary guys. We do it as well for our adults. This is for both the patient. It's a very objective piece of data to help them with their symptoms, okay? It's kind of the, we'll talk about this later, the asthma action plan, right? So with this peak flow, you can see the averages here on age, where you kind of should be, okay? When you do this, this is how you use it, okay? Move the marker to the very bottom, stand up straight, take a deep breath, to your lungs. This teaches you kind of how to do the peak flow, okay? Just the instructions on it, just kind of give you an idea, okay? Write down the number you get. If you cough, do it again, move the marker back, repeat that over and over again, okay? Find your personal best. Take your peak flow each day for 2 or 3 weeks. Your asthma should be under control during this time. Find your personal best, take your peak flow as close to the following times of the day as you can. Between noon and 2 each day, each time after you take your quick relief medicine to relieve symptoms. Any other time, your doctor tells you. Again, these times for taking your peak flow are only for finding your personal best. Because if you notice, back here, you can blow it up on your computer maybe. On this peak flow, if you see to the left is a red one, kind of where you go when you blow. The other two, at the very top, you'll see a green. Okay, in the middle is yellow, that bottom one is red, right here. So green, yellow, awful. Okay? It allows the asthmatic to look at it and say, all right, I'm doing okay today. Or wait a minute, something's changing my breathing. I need to be paying more attention to day to day of like, is it changing more, is it getting better, or what's going on in the next couple of days, okay? Because again, it goes back into the asthma action plan of, hey, if you're in the yellow zone, start looking at some stuff. If you're green, you're good. Stop. Right? Red, get your butt somewhere. Okay? Peak flow, peak flow. Alright, the next few slides. Alright? Asterisk, board, whatever you want to say. Know this stuff, know this chart. Okay? Because a lot of maybe test questions will fall into that tertiary question where they give you the symptoms. You have to figure out they're mild intermittent asthmatics, moderate persistent asthmatics, moderate persistent, moderate severe asthmatic. Because that will judge on what steps you take as far as treatment. Okay? Mild intermittent, symptoms less than a week. Mild persistent, more than twice per week, but not daily as far as shortness of breath or cough or any of their symptoms. Okay? Moderate persistent, daily symptoms, severe throughout the day. Nocturnal symptoms, intermittent, again, less than twice a day per month, if that. Mild, having nighttime symptoms 3 or 4 times a month. Moderate, more than once a week, but not every night. And severe is every night. So, and I can go through this, but you guys can read it, because it is, you need to know this, okay? As you scroll down on that slide, and again, there will be several slides that will be very similar to this, because it breaks it down, intermittent, and the mild persistent, moderate persistent, and severe persistent. Look at that bottom, recommended treatment strategy, okay? Intermittent, if you're in my office, there's no such thing as intermittent, okay? You're just using a regular as-needed bronchodilator, or short-acting bronchodilator, and you're probably using it before you go work out, and that's it. You don't need to be in my office, that's the case. Mild persistent, again, what are you going to start out with? Most of the time, ICS, inhaled corticosteroid, right? Cromolyn, we don't use. You can add singularity to that if you think it's more, again, extrinsic. Have you guys had the task yet go over the medicines?
It's Monday over asthma.
The medicine? I got inhalers you can play with. I've got other stuff. I'm sure you'll pass through that too. Yeah?
She will.
Oh, you have it Monday?
Yeah.
You didn't have it?
No, week coming up. She likes to have the disease process discussed first before she talks about it.
Makes sense. All right. Again, step 2. See there, please don't use theophylline. If you even think about that, please get them to see a pulmonary doctor first, please. It is an old school medicine. You're going to have tons of side effects. Sometimes it's not the greatest. A very particular patient will get theophylline. One of those that we tried everything, nothing else works, hell, let's just give them theophylline. See what happens. I have one doctor out of the 11 I work for that uses theophylline. He also just turned 70. Right? So if you're using theophylline, please send it to my office. All right. Again, moderate to persistent. Step 3, ICS plus LABA or medium dose ICS. Alternative, again, kind of the same thing. Severe, step 4 and step 5. Medium dose ICS plus LABA. You can add a LAMA in there. Muscarinic agent, long-acting anticonvulsant. You guys have that? Stop me if you don't. We'll go over it, I promise. All right. Again, kind of the severity of symptoms. It goes back. It's however you want to look at this slide. Whatever works best for you, just know it. I gave you different examples because again, I gotta see it to understand it, and everybody's different. Okay. I put this slide on here because again, no kids, don't do them. 0 to 4 years of age, is you will see them in urgent care. I promise you, you will have a 16, 17-year-old mom that will bring her newborn in. I mean, I've had it happen to me, right? Maybe it could have been a month old, and you could hear them from the door, okay? While she's playing on her iPhone. Had it happen. Babies are scary. Okay? So here's kind of the stepwise treatment for kids, right? You will notice as we go along, 0 to 4, 5 to 11, 12 and greater. There's very subtle changes, okay? It usually starts about step 3 and step 4 and on up. Step 1 and 2 are usually the same, all right? I won't go through these because they're the exact same, okay? Except for stepwise, I'll kind of say this. Every asthmatic will be different. Just like every diabetic, some medicines will work for one, it won't work for the other. Some people love ProAir, some people love Ventolin. It's still albuterol, it's just a different propellant, and they like it for whatever reason. Okay. Some asthmatics don't complain as much as others. You'll have a hard time figuring out, do you increase ICS, do you not? Do you do this, when do I pull the trigger and add the LAMA? Again, it goes back to symptoms. How often are you using your rescue inhaler? Okay? How often are you using your nebulizer? Do you have a nebulizer? Medicines, I won't go through this very much in detail because you're going to get it here pretty soon. Again, like I said earlier, there have been more medicines that have come out in the last couple of years than have been 10 years or 5 years I started. I usually give this to my students when they rotate with me because it gives you a list of all of them, their generic names, the doses of them. That way it's a lot easier. There's some inhalers in here, we'll play with them and ask me how to use them. Again, on some of these, let me go over something real quick. I want to show you something. So anyways, before I get to that, beta-2 agonist, again, it causes bronchial relaxation, acute acting, albuterol, levo albuterol, long-acting, salmeterol, formoterol, then Dalderol, Stirverde. Again, Stirverde has been out a couple of years. Formoterol, Fordil, you'll see that one in a few other combo medicines. On the levo albuterol, I use Zopinex. So this is how I describe Zopinex to patients. Okay? Is anyone here asthmatic? lung issues? Holy crap, yeah. There you are. All right. So albuterol, let me ask the half the class. Albuterol make you shake? No? Yeah, they do too. Sometimes albuterol can make you shake quite a bit, okay? Even the nebulizer treatments, even if I did one, I'd kind of have to sit there for a little bit. My elderly population, it can really make them shake quite a bit. Heart palpitations, watch the AFib, okay? So, some patients just cannot tolerate albuterol because it makes them shake so much or throws their heart rate into AFib and you can't do it, right? You have to document that for insurance purposes because most insurances will not approve levo albuterol because it's so expensive. So the way I describe levo albuterol to patients is that the chemical engineers, the smart people of the bunch, took the chemical strain of albuterol, found this chain that makes you shake like crazy, they took it off or left it out, levo albuterol, right? And tripled the price. That's Xopenex. Okay? Anticholinergics, a lot of times in asthmatics, you won't add this until later down the road. If you have them maxed out on ICS and LABA, you kind of hold on to that LAMA until you really need to. Okay? The long-acting LAMA, or long-acting, short-acting, a lot of times that's going to be in your Duodev or Comavent inhalers. Or Duodev nebulizer, Comavent inhalers, sorry. That's the same stuff, by the way. Okay, Comavent and Duodev. One's nebulized, one's a little twist inhaler like this. Then you go to corticosteroids, ICS, Alvasco, Q-Bar, Asmodex, Flovent, Pulmicort. Choose any of them. Again, you'll have some patients that love Alvasco, some people hate it. It's just, you're practicing medicine. You are trying out what you can, what they like, and what insurance covers. Okay? Combo, Advair, Symbicort, Brio, Delera. All of them are different devices. Advair is a disc, Symbicort's a MDI puffer, Brio is the new kid on the block. Easiest one to use. That easy, okay? Take into consideration dexterity of your patients. If you get an old arthritic lady in there, or man, they will not be able to use this thing, I promise you. This is a twist one, okay? Trigger, if your thumb is on that trigger, it goes off. Make sure it's shut, twist, it goes. Okay? Yeah, it's magic, right? That's how I do it to patients too. Alright, here we get into the biologics. Okay? When we start maxing out therapy, or if you find a patient that you know is such a horrible allergic asthmatic, and you do blood work on them. Zolair was one of the first ones to come out. Okay? And that's when we talk about drawing blood, not just for allergen panels, but an IgE. Okay? IgE, part of our immune system, right? Immunoglobulins that fight off stuff. Okay? With certain patients, some people dump out way too much IgE. Okay? So when they get around, I don't like cats, catnip. Okay? Your body says, what are you doing? Overabundance and just releases it, get rid of it, right? So, what Xolair does, and you can kind of read it here as far as inhibits IgE binding to the high affinity IgE receptor on mast cells and basophils. Decreasing bound IgE, the activation and release of mediators in the allergic response, early and late, is limited. Serum-free IgE levels and the number of high affinity IgE receptors are decreased. I'll put it in very basic terms. It binds to IgE before it binds to something else. So it kind of slows down that abundant release. Okay? For IgE, it's probably 0 to 100, normal levels. We consider anything above 35 to be a little bit abnormal and to qualify for Xolair. The dosing depends on your IgE level and your weight. You can get anywhere between 150, 225, 300, 375 every 2 to 4 weeks. It's not approved for anything above an IgE over 700. I've had 2 people with IgEs over 9,000 before. I had to recheck the lab because I thought my lab was broke. 9,000. Only have it twice. Look at that. Okay. The new guys that have come out are Nucala, came out probably within the last year or so. So when Xolair came out, we had these patients that kind of fell in a kind of a black hole, really, because they had horrible asthma. We sent them to an allergist. The allergist said, "You are so highly allergic to so many things, I can't give you immunotherapy because I'm afraid you're going to have a horrible reaction. You're out. You don't qualify for Xolair because your IgE is not high enough." So I've had patients that just go with an ACT of 6. You guys know what ACT is, by the way? Asthma control test. Okay? I may have a picture of one in here. Asthma control test. Ask about 5 questions of, 1 through 5. Okay? You score 1 through 5. How well do you feel like your asthma was controlled? Have you had more symptoms over the last 4 weeks? Things like that. I should have it in here. Give me your score. So again, 5 is the lowest you can get. High of 25. She lived 7, 8, because that was her daily thing of using her rescue inhaler 10, 12 times a day. That was her norm. Okay? She got on Nucala. She's now in the teens. I mean, her ACT is 15, 16. Only using her rescue inhaler 4 or 5 times a day. That's a win for us, right? And she knows if she misses her Nucala by 2 days, she knows Nucala has been a phenomenal drug with us. It doesn't take into consideration your IgE, it's your eosinophil count, okay? When we do blood workup, we always do a CBC, check your absolute eosinophils and see where it's running, because it may not be an IgE thing, it could be an eosinophilic type reaction. Okay, Nucala, it's an IL-5 inhibitor. Again, you can read it on here. IL-5, major cytokine responsible for growth and differentiation, recruitment, activation, survival of eosinophils. Again, associated with inflammation, important component of pathogenesis of asthma. By inhibiting IL-5, reduces the production and survival of eosinophils. You've got to love that last sentence, right? The mechanism is really not known. But it works, I promise. The newest one, Fasenra, just came out probably this year, actually first of the year. Again, it's an IL-5 inhibitor. It's a little bit different as far as injectables. It's 30 milligrams every 4 weeks for the first 3 doses and once every 8 weeks. Again, you're really not checking this until if they're uncontrolled or you know just by the first few visits that you're a horrible allergic asthmatic, then start kind of working down the pathway of let's get some blood work, let's see other possibilities it could be. Treatment, again, it goes right back to all those slides we showed previously. All right? Mild intermittent, moderate persistent, severe persistent. Okay? Changing the medication curve, long-term level. One of the main goals you want for your asthmatics is to get them on the lowest dose possible and keep them well controlled. If you were sent to my office, I'm going to max out your therapy, get you under control, and start backing off. The asthmatics don't dink around and just kind of, hey, we'll just get them under control, then you can back off. Once you get them stabilized on the lowest dose, that's great. If you keep them on the max stuff, you really have nowhere to go. Okay? Quick relief plan is the same for all the classifications. Short-acting inhaled beta-2 agonist is needed. That's your albuterol, lead albuterol. Intensity of treatment will depend on severity of exacerbation. Use of short-acting beta-2 agonists greater than 2 times a week may need to move to long-term controlled therapy. If on long-term controlled therapy, using a short-acting beta-2 on a regular basis, step up. Again, please go over that slide. Oh wait, there's the slide. Okay? Asthma inhalers. And in fact, I don't know when this one was done, but there's probably 4 or 5 more inhalers on that one than this slide. Again, it goes back to know your triggers and asking questions. Okay? Then we go into stepwise approach of what to work up. Check an IgE. Okay, IgE binds to allergens and triggers. The release of substance from mast cells that can cause inflammation. Draw aminocaps is kind of what I talked about earlier. Midwest panel, trees, grass, weeds. Perennial panel, molds, cat dander, dust mites, cockroaches. And you'll just have to see what your facility does as far as, it may be a different lab order from Baptist to Deaconess to Saints to OU to Mercy. You just have to kind of figure it out when you get jobs. Okay? Again, could they be a Ziller candidate? Could they be a Nucala candidate? A Sinra? Asthma management. It's really the same. There are several people, and I think you have one later today. You can become an asthma educator. They are really good at what they do, right? Teach inhaler use. I put this in red because it is very important. I will show you a video later, and I will show you how important it is. Okay. Discuss roles of medications. Our job, trust me, the reason why patients want to see PAs. We explain stuff, we educate them. Don't just throw an inhaler at them. Tell them what it's for, tell them about the disease process. Trust me, they will see you every single time. And they are more apt to take their medicine if they know what it's for and what it's doing. Okay, especially with asthmatics. You just say, oh, it's a steroid and bronchodilator. It doesn't mean anything to them. Okay, explain to them like, hey, you flare up, you get inflamed, that's the steroid. You lock up, you restrict, that's what the bronchodilator is for. When they know it, they see it, they'll take their medicines, right? Know the self-management action plans. We'll go back in a little bit. Environmental control measures. Again, if they know the trigger's exposed, stay inside. There are a dozen apps, especially here in Oklahoma. It helps. That tells you the allergen count for that day of whatever is out. Okay? They will know. Okay? Review treatment plan every 1 to 6 months. Again, step down or step up. Okay? If they're not doing well, consider stepping up. What's going on? Is it a bad time of year for them? Okay? Again, good asthma control. It goes back to that slide. Daytime symptoms less than 4 times per week. Nighttime symptoms less than 1 time per week. They can do whatever they want to as far as physical activity, exercise, mild infrequent exacerbations. Some patients, some asthmatics can kind of get themselves through just by being proactive. I stress that with all my asthmatics. Be proactive in your own care. Okay? If you feel something's getting bad, if you have to use your rescue inhaler, so be it. Okay? Just don't get behind the 8 ball until it's too late. No asthma-related absence from work or school. Beta agonist use is less than 4 times a week. Again, peak flow without much changing. Okay? Again, man, I really counted this down, right? Mild exacerbations, minor changes in airway function, minimal signs and symptoms. Most patients respond quickly to inhaled short-acting beta agonist. If you have a nebulizer in the office, if you feel like you need it, see, sometimes, especially what I refer to as lungers, they've learned how to breathe. They will fool you every time. Make them breathe. If you're in my office, I will make you breathe on the verge of passing out. It's not fun, but I do it. Okay? They've learned to breathe because they know if they breathe too hard, they either cough or lose their breath. So they'll take that breath, okay? Make sure you have them breathe out, a good breath in and breath out, okay? I teach that to my students all the time because this will happen to you, I promise. You'll go in there, listen to somebody, they sound fine, no worries, they're good. I go in there, breathe. You hear all that wheeze? No. Yeah, make them breathe, okay? If not taking inhaled corticosteroid, initiation may be indicated. If taking inhaled steroid, you may double it, check their peak flows, and see where they stand. They're kind of that low yellow or that red. If it's flare up, they're just not doing too well. Moderate to severe. Do they need hospitalization? Watch for tripod positioning, nasal flaring. Again, test questions, they'll describe a patient like that. Okay. Severity of airflow obstruction, course and severity of prior exacerbations. If you have access to their records and you know the last time they had a flare-up, it took them X amount of steroids, X amount of days to get over it, or if you're having frequent flare-ups, be careful with that patient because they could very well end up in the hospital. Discharge criteria, FEV1 greater than 7% predicted or personal best. If they're in the hospital, they're not checking this. They're just checking to see if their saturations are fine and they can walk without dropping. They'll get them out of the hospital. So they don't really check that. All right? Slide again. Pediatric asthma. Again, you can read this slide if you want to. You probably need to, pediatric purposes. Okay? Short acting for kids, less than 2 to 5, greater than 5. Okay, salmeterol, cromolyn, budesonide or pulmicort, inhaled steroid. I wish I had some of these for my adult patients. Okay. Treatment for kids without exacerbations. Increased frequency of med every 2 to 4 hours. Prednisolone, 5-day course of oral steroids. You can continue or begin oral antihistamine. If signs and symptoms last greater than 7 days, or patient develops fever, fatigue, speed reduction, etc., consider antibiotic treatment. When to worry. Nasal flaring, retractions of stomach, chest muscles, lack of wheeze, silent chest, fatigue, floppy baby. Again, very scary to see. Always have ER and ambulance number on board if they walk into your urgent care clinic like this. Okay? All right, 12-year-old African American male with history of asthma presents with complaints of 2-month history of nighttime cough with shortness of breath 3 times per month. Need to use albuterol inhaler 3 times per week during the day. Nice chest pain, nausea, vomiting, rash, or any other symptoms. Patient is unsure of his peak flow as he does not have a peak flow meter at home. What's his classifications? Or his classification, I should say. Go back to this. So nighttime cough 3 times a week. He's not waking up to use his rescue inhaler. So, yeah. Okay, move up to step 2, add low dose. Any ICS, continue albuterol. Asthma action plan, provide peak flow. Teach them how to use the peak flow, how to take the meds, follow up in 4 weeks to recheck. Okay? Some other little questions here. 34-year-old white male calls your asthma clinic. Decreased peak flow this morning from her usual. He. Okay? He was doing fine until yesterday when he went out of town with his girlfriend for the weekend to visit her parents. He noticed a cough, chest tightness, occasional wheeze, and a shortness of breath upon waking this morning. Peak flow is 80% this morning, usually 90-95. There were 3 dogs in the house, and he reports his allergic to animal dinner. He's had asthma for 15 years. He has albuterol MDI 4 times a day and as needed. On fluticasone, 2 puffs of BID, and loratadine, allergies, aspirin, peptide. What triggers could potentially be inducing this patient's acute asthma? So there's a dozen times, right? Dogs, right? Stress. The girlfriend, the trip, yeah. Right?
Wait, is it a man or a woman?
A It's a guy, he's with his girlfriend, I just put he there for, I don't know. And, yeah, it's a he. What treatment would you recommend? Again, those are his medicines.
Not go around the dogs.
New girlfriend? Alright. But yeah, so here, his peak flow is only 80%, and he's usually 90 to 95%. Okay? He's using the albuterol inhaler quite a bit. He's only on some ticazone. That's it. Okay? And an allergy medicine. So, would you treat him just for a flare-up? Or would you go ahead and increase or step up his therapy? What would you do? Yeah?
I would probably give him something to take before he knows he's gonna be predisposed. If not, maybe something that would be in emergency cases,
He's got it.
then you got it. You did it.
But he's worse.
Step up.
Step up? Yeah, do step
But
up.
I thought the max for albuterol was 8 puffs a day.
Okay. He's 2 puffs 4 times a day right there.
Well, yeah, but you can't step that up.
Right. So what else would you do? Again, you got, he is flaring up right now. You got to run something that flared up his asthma, so his peak flow is a lot less. So are you treating that for just an acute event that he's flaring up? Yeah? Yeah. What would you do? He's wheezing, by the way. Wheezing a lot.
Bronchodilator
Yeah,
and
prednisone.
corticosteroid.
Prednisone.
Oh,
Yeah.
prednisone.
Decreases
Corticosteroid.
inflammation, yeah. Because if he's that bad, and he's using his, like she said, max out on his short acting, 2 puffs 4 times a day, that's 8. And yes, that's a low dose cortisone. Give him benefit of the doubt on that before we start just increasing stuff. Give him benefit of the doubt, right? Let him get away from the dogs. Give him a little short course of steroids. Get him out of that environment. See if he improves. You may not have to stepwise right then, okay? If he's away from that environment and he's still using that puffer that often, then consider stepwise, okay? All right. Again, present to your ER. Increased cough, shortness of breath, wheezing, past 3 days increased cough, dyspnea, chest tightness, asthma for 2 years, recently hospitalized with pneumonia 3 months ago. She's on an albuterol MDI, unsure of dose, because a lot of times it's, I take the red inhaler. That's what you usually get. Physical exam, an anxious young girl, moderate respiratory distress with audible wheeze, shortness of breath, coughing, suprasternal retractions. Okay. Vitals, pulse is 120, respiratory rate is 30, O2 sound Ramirez 92%. Tachy but regular, prolonged expiratory phase. Volatile expiratory wheeze, decreased air movement. Signs and symptoms?
Retraction.
Yep. Yeah, yeah.
Heart rate.
Yep. So, severity? Okay. What treatment?
Oxygen.
Okay. Especially with the ER. Yep. IV steroids, NEP treatment, get everything started. Kids go bad quick. Okay? Is it?
Take it, just a very quick break. We got tons of stuff to go through.
Go.
So, or does anybody have to?
Yes.